Meant is if there is damage to the pituitary due to the injury, then the clinical effects will be multiple endocrine problems or selective growth.
It would be an infundibulum stalk resection or a stalk injury. So all the pituitary hormones, they are connected, the anterior pituitary and posterior pituitary through the stalk. So it will be multiple pituitary hormone central. Meaning hypopituitarism could be the cause of growth faltering.
So in this case, less likely.
One of the history, though it is there, that should be kept in mind as one of the etiological causes in the history. We need to see history is giving you multiple clues to a possible provisional picture diagnosis.
But in the same way, we can exclude craniopharyngioma and other space-occupying lesions also in this case.
Craniopharyngioma the symptoms would be of craniopharyngioma first, rather than the short stature. So craniopharyngioma is somewhere sitting in the cellular suprasellar region. So you have pressure symptoms of the optic chiasma, you have, like you said, visual field defects, etc. So that again, it's a progressive kind of a disorder. So intracranial space occupying lesion symptoms would be more prominent as compared to short stature.
So can you quickly go through your negative histories, because I think some of them become irrelevant in this kind of a story. So can you quickly go through that?
No history of reduced appetite or any history of recurrent LRTI. No history of headache, nausea, vomiting or diplopia.
So how about this history? No history of headache, nausea, vomiting, diplopia. For a thing that started in early childhood and has gone on for so many years, would that be relevant?
No.
Okay. Then?
There is no history of polyuria, polydipsia or oliguria. It will not any renal RTAs.
Yeah. So means again, it's okay, but as sir said, these children, if this was there, the child would not be active, playful, all that. Yeah. Go on.
No history of constipation, lethargy, dry skin, hoarseness of voice or any cold intolerance.
So that we already discussed in thyroid. Then?
No history of any chronic diarrhea or bulky stools for malabsorption.
Okay. Fine. So now, on history, what do you think are the possibilities that are remaining?
If I can just interrupt.
Yeah, please.
In the birth history, it's important not only to know about the birth weight and gestation and mode of delivery. I think you mentioned that this was a cesarean. What did you say?
Home delivery.
Home delivery.
Okay. I'm sorry. So this was a home delivery, and if suppose it was known to the parents, it would be important also to know whether there was a breech delivery, and because breech is supposed to be associated with multiple pituitary hormone deficiency or hypopituitarism. Breech is not only growth hormone, it is part of multiple pituitary hormone deficiency. And also the neonatal symptoms of prolonged neonatal jaundice, neonatal seizures which are attributed to hypoglycemia could contribute or could be pointers towards ACTH deficiency, hypocortisolism, growth hormone deficiency. So newborn history is not only in terms of the size at birth, but also the mode of delivery, presentation, and neonatal illnesses.
Sanjay wants to make a point.
One subset we have left out is skeletal dysplasia. They can present without any history, with only short stature, and they may be picked up only on examination. Like these morpheos and all, they come only with short stature.
Yes.
So now on history.
Rajesh, can I make one announcement? There has been a delay in the broadcast, in the sense it's being transmitted a little late. But those of you who are experiencing problems at on your computer, it's because of buffering issues. From here, the broadcast is going properly. In any case, whatever you missed, you can see it in the recording.
So what are we left with on history? What possible differentials are we left with on history? Then we go on to examination. So chromosomal 1, then constitutional delay 2, then
nutritional.
Okay. Nutritional, then what else? Growth hormone you have ruled out.
Yeah, so so the hormonal causes also, meaning these are your differentials based on the history. So we spoke of nutritional, though she said calorie deficiency is 860 calories. That's what I guess you mentioned. 680. 600 kind of calorie deficit. chromosomal we are yet to find out whether it is chromosomal or not. It could still be a part of multiple pituitary hormone deficiency, and like Dr. Sanjay Prabhu said, maybe a skeletal dysplasia still forms a differential there.
So one thing is there that the nutritional deficiency will not cause a very significant short stature. See, with nutritional deficiencies, mothers don't come to the doctor because the child is short. They will come for some other complaint. So a significant short stature, would it be because of a nutritional deficiency?
When you say,
if it is early onset, then it can be, no?
So when you have phases of
Significant.
yes, the time lost is lost. For example, if a baby is in an infantile growth spurt and there is significant failure to thrive, we call it more of failure to thrive in that initial few years of life. And if the replacement intervention is not adequate, that 24 centimeters per year and then 12 centimeters per year, that velocity the baby will not be able to catch up subsequently. So if you have phases of deprivation and plenty, that could still be a nutritional issue, phases, meaning initially there was a lot of issues of nutrition in the first 2 years. That's why besides SGA, the other major chunk of babies who don't catch up is children with failure to thrive, because that happens to be an important subset of babies who don't catch up. You do what you want to do subsequently in life, that velocity lost is lost.
So we'll get on to examination. Tell us general.
On examination, the child is active, alert, is conscious, cooperative and well oriented. Vitals on examination shows afebrile with a pulse rate of 96 beats per minute, regular in rhythm, normal volume, no radioradial or radiofemoral delay, and all peripheral pulses were equal and well fed, with a respiratory rate of 18 per minute, abdominal thoracic, and blood pressure of 96 by 66 millimeters of mercury, which falls towards the 50th percentile. Anthropometry wise, her height is 107 centimeters, which falls to below -3 standard deviations. Weight is 16.4 kg. BMI is 14.3, which is between -2 and -1 standard deviation. Anthropometry wise, her height is 107 centimeters, which is below -3 standard deviation. Weight of 16.4 kg. BMI of 14.3, which is between -2 and -1 standard deviation. Her upper segment 73 centimeters, lower segment 34, with a ratio of 2.1. And the mother's height is 155 centimeters.
One sec. So can we get into the interpretation of this anthropometry? So while you said it's less than -3 standard deviation, that's fine. But how will you compare height with weight? You said height is 107. So what does that mean to you?
She's stunted.
Yeah, but what else? So height age is 4.5 to 5. And what is the weight?
16 kg, 16.4.
What does that tell you?
4 years.
So is there a great discrepancy between height and weight affection? So what is weight for height? Almost normal. So how do you rate that when you think of different groups of causes? Yes? Anybody?
Can I ask you what kind of reference standard you used? When you're saying standard deviation, -3, -2,
WHO group standard.
That's available for 11-year-old.
height is available, weight is not available.
How did you get your weight standard deviation?
Weight standard deviation I didn't get, so I calculated the BMI, which is BMI is available in the WHO group standard.
So from BMI you back calculated the weight and I looked at the weight. No. So you should use, I guess, the same reference standards for interpreting your data of both height, weight and whatever else you want to interpret on. So WHO is useful for children less than 5 years. If you're going to use reference standards, the standard deviation scores are not available in Indian reference standards, say IAP growth charts or even K.N. Agarwal growth charts. The charts do not give you the SD. The standard deviation is not available on the chart. What is available is the centile. So if you're going to look at 5th centile, 10th centile, 15th centile, 50th, so on, 25th, 50th, 75, 95 and 97. So you have centile lines, K.N. Agarwal. You have centile lines, IAP growth charts. IAP growth charts has lesser number of so you need to be aware of what kind of reference and standard you are using, because if this child was less than 5 years, even I would not have bothered that what kind of reference standard you used. So interpreting in relation to centile is what is available to us for this age. That's one. 2 years. The interpretation has to be with the same reference standard. I can't interpret CDC for height and WHO for weight and something else for BMI. It has to be same reference kind of curves to be used. And the interpretation of, after seeing what is the absolute centile growth parameter is on, and then you correlate which is affected most to find out what is the type of short stature this baby has. So we said, assuming we'll go by the same, can you plot it on a, do you have any other growth chart with you? So can you plot it on that? So where is the weight?
Dr. Anita, can you come in the center and do it so that they can focus on what you are doing? So we all learn how to chart.
Is 11 years 6 months and her height is 107 centimeters.
ये chart दिख रहा है? You go there, closer to that. Chart पे आ रहा है क्या?
Paper दिखाओ.
You plot it here. 11 years 6 months. Weight is how much? 16.15, 16.4. So never circle your dots. You always need to put a dot and not circle the dot. So the weight is here. If you can see, you can show this for them. So the weight is here and the height is here. Can you all see that? So height is here. Sorry, this is the weight and this is the height. And we are plotting this child on a WHO growth standard. Right? This is IAP growth chart. We are plotting this on a IAP growth chart. Weight is here and height is here. Now what is the height age? The age at which this height falls on the 50th centile would be the height age. So the height age here, if I can see, is about 6 years. And the weight age is the age at which this weight falls on the 50th centile is about 7 years. The weight age is about 7 years and height age is 6 years. So what does that mean? So we talk of weight age and height age. Of course, you can talk of SDS also, but with reference. But weight age is 7 years and height age is 6 years. Means what? Weight is more affected or height is more affected?
Height age is more affected. Height age is
more affected as compared to weight age. Weight age I said was 7 years and height age is 6 years. So height is more affected as compared to the weight. So what conditions in which you would get height more affected than weight? Which one? Chronic malnutrition. At 11 years of age, one could be malnutrition. What else? So in which conditions weight is less affected as compared to height?
Constitutional disease, familial short stature.
Endocrine causes, that's correct. So endocrine causes, it can range anywhere from a normal variant to endocrine deficiencies Which of them can have height more affected amongst the endocrine deficiencies? Is everything, right? Even pseudo-hypoparathyroidism, the child could be short, high growth hormone deficiency, weight may not be so much affected as height, hypothyroidism. All those causes which we said, the height is more affected as compared to the weight. If the weight was more affected than height, what would you think of? If the child was more thin than being short, what would you think of?
Chronic malnutrition.
But when you talk of chronic malnutrition type of a situation in an older child, it usually means secondary malnutrition. That means systemic disease. So, it's not just nutritional inadequacy, it is systemic disease.
Yeah, so systemic, when you say weight is more affected than height, endocrine causes should be out of your mind. They are not the causes. When your height is more affected than the weight, then yes, an endocrine evaluation is required. Weight is more affected, you think of systemic illness to rule out the systemic various illnesses. What else? So what was this child's BMI? Is it required to calculate BMI?
Yes, ma'am. To rule out any chromosome, like in the conditions where there is associated obesity.
So, how would BMI help you in this case? Will you calculate a BMI? Because the back calculation happened from the BMI, right? So, what is this baby's BMI?
14.3.
So how do you interpret that BMI? Is she thin, wasted, obese? So you look at BMI in relation to the, again, centile lines, right? So though we have a case later on with the BMI, but BMI, if it is between your, meaning less than the 97th or an absolute number of less than 25, those children are not obese. BMI less than 25, less than 97 centile. There are differences between overweight and obese. I think we'll do that later on. So BMI is what you calculate. So in terms of anthropometric parameters, you're speaking of height, you're speaking of weight, BMI. Anything else you would want to check?
Upper segment, lower segment ratio.
How did you get that? Your ratio was 2. So what do you mean by that 2 of ratio?
The lower limb length is much affected than the upper segment.
The upper segment is longer than the lower. So is this proportionate or disproportionate for her age?
Disproportionate.
So what is expected at her age? What is proportionate for her age?
1.9:1.
Yeah, at 11 years, almost like 0.8, 0.9:1. So she's having an upper segment which is 2:1. What is it in a newborn?
1.7:1.
So you mean to say the proportions are even less than a neonatal proportion? Meaning the limbs are shorter even than... So how do you measure the upper segment, lower segment?
I was about to ask that. How do you measure the segments at this age?
How do you measure the upper segment? Well, how did you measure the upper segment?
The lower segment from the upper part of the pubic symphysis till the floor on the standing position.
Right.
And then subtracting this lower segment from the total height, we get the upper segment.
Okay. So that is how you're supposed to do. But both should be in standing position. Your height should be in standing and the lower segment measurement should also be in standing. So what does that implicate? If suppose your measurement was correct, what does that 2:1 imply?
Disproportionate group.
What are the causes possible?
Like skeletal dysplasias usually.
Which one?
Achondroplasias and with either short trunk or short limbs.
Are you talking of short trunk or short limbs?
Short.
Achondroplasia. Disproportionate with this kind of a ratio, what are you talking of?
Short limbs.
Short limbs. So achondroplasia is a short limb dwarfism. The trunk is quite alright. Okay, one is...
Does it really look like 2? I seriously...
No, we'll do that again, but then maybe, yeah. What other things you're thinking of when you're having 2 of ratio besides achondroplasia? Anybody?
Short-limbed, disproportionate, besides achondroplasia, what else ma'am is asking?
Metaphyseal dysplasia.
Metaphyseal alone will be usually spondylometaphyseal. So whenever you say spondylo, your spine gets affected. So you do have an upper segment shorter than the limbs. Okay, besides this, you have any other? Besides achondroplasia, do you have any other condition? Very good, rickets. Okay. Besides rickets, hypothyroidism, congenital. congenital hypothyroidism.
Osteogenesis is imperfect and cretinism can cause.
Yeah, that's a spectrum of disease, and the disproportionateness more because of deformity rather than per se disproportionate growth. Okay, so we're talking of hypothyroidism congenital, rickets, and achondroplasia. Does any of that fit into this? She doesn't obviously look rachitic, right? Rickets led to gross rickets would have.
Basically, as everyone observed, the proportions don't seem that abnormal, so we'll go ahead, we'll move ahead. What are the other?
Yeah, okay. So we'll take it as a proportionate unless somebody wants to measure it, and then go ahead as a proportionate cause of short stature. Yeah. Okay.
Other examination point?
I took the mother's height to calculate the mid-parental height, which would be necessary. I took the mother's height as well to calculate the mid-parental height so as to see for the growth velocity of the child whether she is falling into the curve of the mid-parental height.
So only mother's height?
Actually father's height also, but father was not available, so I took mother's height.
And how did you calculate the mid-parental height range? We need both the parent height. No target height or range, for that we need both the heights. Often one of the parent may not be available, so you would ask them to give you a rough indication as to how tall the parents are. Ideally you have to measure both the parents. So you can't calculate the mid-parental height range based on one parent's height. What is the mid-parental height range? Meaning, how would you calculate in this?
Anybody from the audience want to talk of mid-parental height? Raise your hand, ask for the mic.
Mid-parental height in the girl child would be father's height plus mother's height divided by 2 minus 13 centimeters. So
anybody else? Yeah, so 13 or 6.5? 13. So half of 13 is 6.5, right? So either you add 16, divide everything by 2. Mother, father minus 16 divided by 2 is for a girl. Mother, father plus 13 whole divided by 2 for a boy. Or you add or subtract by 6.5. Half of 13 is 6.5. That is the target height. How do you talk of range? What is the range? Because target height tells you the 50th centile for this genetic couple, genetic potential. So you need a range between 3rd to 97th centile. So that would be plus minus 8. Some people say plus minus 6.5. So 6.5 also maybe you will be alright. Plus minus 8 is also alright. There is no secular change as yet in our reference numbers. So plus minus 8 is the range in which you take from the 50th centile or the target height. So you need the mother's, father's both heights. Yeah.
Any other examination findings?
Sitting height of any concern?
Yeah, sitting height is important when you are having a statural growth being affected, meaning stem length being affected more than the limb length. So this is usually used when you're having a child conditions where you would check especially for a stature length. See, as such we don't have a reference number for height uniformly used. We definitely don't have reference curves for stem stature length. So stem stature length is available for say child who is receiving growth hormone treatment. The stem stature grows more as compared to the limbs.
Can you explain what you mean by stem stature?
Stem stature is it's called other name for the sitting height. So when a baby sits along with a right angle at the level of knee and on a stool raised from the floor of X amount of measured kind of a stool, and you measure the height from the crown to the buttocks. That is the stem length or the stem stature. So stem length is used for monitoring the growth on therapy, like in growth hormone treatment, can be used in assessing growth in achondroplasia, where the limbs may not grow but the stem length will still grow. It would be useful in children who got say a spinal irradiation or a spinal injury or in special dysplasia, skeletal dysplasia, but you can't. So if in a spinal irradiated baby, say a cancer survivor who's received a total body irradiation along with a spine irradiation, you would want to assess the growth of the spine separately from the whole body, of the height growth. So that is useful in those scenarios. So
neck length important, because people talk about all that, long length, short length.
Actually, if you look at I guess you can add up all the lengths and then say this could be the But if you have a scenario, then that measurement makes a difference. For example, where would a neck grow, say, disproportionately to the rest of the spine? Yes, a child who's had again irradiation to the neck, for example, through thyroid cancer or a rhabdomyoma, lymphoma, those get distorted also, the neck growth as compared to the rest of the spine. But there are no reference standards as to what would be the rate at which the neck will grow, what would be the rate at which, it's known in Western population, what would be the rate at which the stem length will grow. That can be used as a reference curve, but cannot be extrapolated in our children. But it becomes important if you are looking at a cancer survivor with irradiation, you should do the stem stature measurement in each follow-up visit to see whether they are growing adequately or not. On growth hormone therapy also you could check the stem stature. Even growth hormone, even these hands and feet grow at a faster rate. So that in the past we used to make the picture of the foot and then compare it subsequently as to how the foot growth is happening to look at response to growth hormone therapy.
Sorry? Yeah, that's what I was saying. So clinical findings now.
Rajesh, could we ask her to give only the positive findings?
Yeah, we are getting a little late, so tell us only the
frontal bossing is present with marks of suture mark present over the scan. Otherwise, there is a very short neck present. Then there is Tanner staging, SMR stage 2. That's it.
SMR stage 2 means what?
Some important negative findings.
There is no striae and there is no shape of the chest is normal, no skeletal anomalies. Hands and feet are normal. There are no any neurocutaneous markers present.
Frontal bossing, I may say it's not there, somebody else may say it's there. How do we objectively say that there is frontal prominence? Yes, the frontal eminences are prominent. When you say bossing, as you see in say rickets, this is the maximum prominence of the frontal bone. So if you're going to look at this, I don't know whether you can see from there, the rough way of estimating that would be, okay, we go that side. Okay. So rough way to look at that would be, these are the eminences, prominences. If they go beyond the lateral canthus, rough estimation, that's when you say that there is frontal prominence or frontal eminence. This meaning frontal prominence which you mentioned. This is a frontal eminence which are looking prominent, not like a true rachitic frontoparietal prominence which you see. So there is a overhanging kind of a forehead. Forehead is prominent, mild overhanging forehead. The eyes are deep set. She's got, how old does she look when you look at her? Does she look like 11-year-old? So how old does she look? About 5, 6. So roughly around 5, 6 years of age. So there is infantile facies. There is some degree of maxillary hypoplasia. An 11-year-old should have a good well-developed maxillary hypoplasia. Okay. You have to also make a mention of whether the teeth are primary or secondary. I can't see, maybe the central incisors are secondary. Yeah.
It's okay, that camera is there.
So, if you see serrations on the teeth, you're talking of secondary dentition. The absence of serration tells you, and she has more than one row of teeth. So there is crowding of teeth. She has secondary dentition. She has immature facies. She has nice, thin, shiny skin, bit of long kind of fingers. So some of these, and preservation of, isko upar karu. So she is not a wasted short child. You can see the truncal pad of fat is well preserved. So she is not a thin and a wasted kind of a child. This is again telling you that there is preserved truncal pad of fat with immature facies and all. All these phenotypes are features of growth hormone deficiency. So these phenotypic features of growth hormone deficiency are present, evident in this child. Okay.
Anything else on systemic examination, or we move ahead?
Systemic examination, nothing significant.
So what's your clinical diagnosis?
Case of short stature, most likely proportionate short stature. To rule out either isolated growth hormone deficiencies or familial short stature, which could be got once we get the father's height, and to see whether she falls in the middle.
Yeah, I want to say something. The way you go about this short stature case is, first is whether you need to see whether this is short or not. Do we agree she is short?
Yes.
We all agree that she is short. Second, whether she is short for her parents or not. Will she be short for her parents?
Yes.
Because mother, we obviously are looking, is so tall. The father must be, if not taller, at least same height as hers. So even if we take the father's height as the same height, she is significantly short for the parental height. So she is pathologically short. She is short for her parents. And we also found features of growth hormone deficiency in her clinical examination, without features of other chromosomal anomalies which were one of her differentials, like Turner. She didn't have any increased carrying angle. She didn't have other features of Turner. Short metacarpal, hyperconvex nails. Those were not there. So malturned ears, and also chromosomal anomaly, Turner syndrome, especially being in a girl child, they were absent. So she is short. She is pathologically short with phenotypic features of growth hormone deficiency. So don't go into multiple differentials of constitutional delay and all. So those are not the differentials here. This is pathological short stature with features of growth hormone deficiency. You are right in saying maybe this could be isolated, or it could be as part of multiple pituitary hormone deficiency, which you will have to evaluate and further work up.
So, when you were saying whether familial to be ruled out, even if father is not available, you plotted the height on that chart and it was way away from the third centile. So in familial and constitutional delay, it will be somewhat short but not so drastically short. In other words, your height age will not be so low. So for 11 years, a height age of 7 years, that's not familial or constitutional. So just by that you rule it out.
Yeah. Anybody wants to comment on what Dr. Rajesh has said? Anything? Yeah. Yes.
You don't agree?
No, I'm inviting a comment.
No comments for Rajesh. I never comment. Just to make a point that
in a generalization at the cost of simple.
Totally accepted. When you're presenting a case of growth hormone in an exam, it will be a good idea. Though we ask for positive findings only, it's good to mention no midline defect, or at least look for bipedovula and some other subtle signs if they are present. I'm open to correction.
No, obviously you don't agree with what Rajesh is saying. So tell us now what you're thinking.
No. See, the dictum is correct. I'm not agreeing. I'm agreeing with him. The dictum is correct that when the height is way below the third centile, you think of a pathological cause. That's the dictum. Even if the parents are short, even if the parents are, say, pathologically short, you're thinking of an autosomal dominant disorder which is getting inherited into the baby. So the dictum that if the growth plot is way below the third centile, irrespective of the midparental height range, the baby is pathologically short, because it could be inherited as a dominant issue also.
So should we discuss how
So
to go
I think the point that you are adding to what Rajesh said, because I think it's very significant, that even if the child's parents are short, you are saying that it could be autosomal dominant disorder and not to consider it as constitutional. That's the message. I think that's fair.
I think as we are short of time, quickly talk about the bone age expected in this child, and then a bit on hormone test and the treatment. So what bone age is expected in this child?
What do you expect the bone age of this?
Chronological age 11 years, height age 6 years. What would be the bone age?
I think so. It's equivalent to height age and weight age. It's not. It's below the chronological age.
So she says equal to height age. So what is that condition when bone age is equal to height age? Constitutional delay. So in endocrine, what do you expect? So further below the height age.
See, when you speak of bone age, I think you try to understand what it actually means. Bone age, I'm sorry, I'm taking some more time. Sorry? Right. Yeah, that can be done.
You speak already.
Yeah, what I mean is bone age is a indicator of degree of maturation. Height is an indicator of degree of or level of growth attained. Growth and maturation are two different things. When you're going to assess maturation, you're looking at bone age, you're looking at dentition, you're looking at secondary sexual characteristics as features of maturation. So these are the parameters which you assess for assessing maturation. And for growth, you're assessing height, weight and all those parameters. So when you're talking of bone age which is in a short child, when the bone age is equal to the height age, you're saying that the short child also has same amount of maturational delay in terms of bone age. There is a delay in maturation in terms of bone age. So when bone age is equal to height age, which is less than the chronological age, assuming that the short child is within mid-parental height range, then you can talk of constitutional delay in growth and puberty. Otherwise, the degree of bone age retardation...
Can you say that again slowly?
Right. So, if in a short child who is short but the height plotted is within the mid-parental height range, and that is a genetic variant of a short stature. He is not pathologically short. So we know that we have two genetic variants of short stature. One is called the familial short stature. The other one is the constitutional delay in growth and puberty. Like when we say delay, the delay is in the form of maturation. So when in a constitutional delay in growth and puberty, you have bone age which is as delayed or as slow as the height age. So bone age will be equal to the height age in constitutional delay in growth and puberty. Whereas in familial short stature, there is no delay. The child is short. So bone age will be same as the chronological age. So in a familial short stature, bone age will be same as the chronological age, which will be more than the height age. In these two conditions, when the child is short and the height is within the mid-parental height range. Short child with height within mid-parental height range, these formulas fit into a CDGP or FSS. But if you are talking of a systemic illness, for example, a child with congenital heart disease or a systemic illness, what will happen to the bone age? The child will be short because he has a systemic illness. So chronological age would be more and the height age would be less than the chronological age. What will happen to the bone age? There would be some maturational delay, but it will not be as delayed as the height age. So chronological age would be more than the bone age, which will be more than the height age in a systemic illness, malnutrition, etc. So we are talking of systemic illnesses, malnutrition. That's correct. So when we say bone age equal to height age and the child's height is within mid-parental height range, this condition is constitutional delay in growth and puberty if the height is within mid-parental height range. Is that correct? Are we all right? So if there is another scenario, I think I'll go on this side. Chronological age is equal to the bone age, which is more than the height age. Assuming that the height is within mid-parental height, this condition is familial short stature. So if you have a chronological age which is more than the height age, which is more than the bone age, this means, what does this mean? What does this mean? The maturation is much more affected as compared to the height. So what affects the maturation? Which endocrine? Thyroid. So you would have hypothyroidism as your underlying cause when the degree of bone age delay retardation is more than the height age and as compared to the chronological age. When you have a chronological age which is more than the bone age, which is more than the height age, what condition here I said? Systemic illness and anything else like malnutrition, even other endocrine causes like growth hormone deficiency, all those illnesses can have less significant bone age retardation as compared to the height age. If you get chronological age, which is less than the height age, which is less than the bone age, what does this mean? What does this mean? This child is 7 years, has a height of 10 years, has a bone age of 13 years. So we are having a precocious puberty. So the bone age is very much advanced in pubertal precocious puberty. When you have pubertal androgens driving, the bone age maturation is much advanced as compared to the height age or the chronological age. So you have these various combinations of bone age, height age and chronological age.
So quickly, how do you make or confirm the diagnosis of growth hormone deficiency and how do you treat? Quickly, in 2-3 minutes, then we move on to the next case. Anybody wants to speak?
I didn't get your question.
No, how do you confirm the diagnosis?
How do we confirm the diagnosis? If we are saying money is a problem, various things are an issue, I want to confirm I'm suspecting growth hormone deficiency, I want to confirm that.
First we have to check the growth velocity over a period of 6 months to 1 year, like whether she's...
that doesn't hold true at this age now. She's come to almost at 11 years. She's lost a lot of her age in terms of growth available to her. So we need not wait for 6 more months because we are saying the height age is 7 years. It's not expected to spurt suddenly. Okay, so that may be not indicated right now. So what will you do?
Do an X-ray of the wrist for the bone age. For the bone age.
Okay, which wrist?
Left hand wrist. Actually any wrist can, left hand wrist is, but any wrist can be.
Yeah, so when you say bone age, you do the X-ray of the left hand, wrist to the tip of finger. That's specifically what you ask for when you want to do the bone age. And then you compare it with an atlas, compare it with a scoring system. There are various ways of assessing bone age. Okay, one you'll do the bone age. Why do you want to do the bone age? I said I don't have money. Anyway, you'll do the bone age. If you don't have time, we'll skip those things. What do we...
Just finish in 5 minutes and we move on to the next.
Okay. Why do you want to do the bone age? It will be retarded, no? Like we said in our, it will be less than the chronological age, maybe a bit better than the height age. But why do you want to do the bone age?
Therapy.
Yes. So, number of years of growth potential this big girl has. She is 11 years old and her height is like a 7-year-old. Suppose you get a bone age of say 8-9-year-old. So she has so many more years further to grow. So to assess the growth potential this child might have, you can also predict your adult height based on the bone age, right? Okay, you do bone age. What else will you do?
Serum would like to do a growth hormone stimulation test in such a child.
Okay, so what growth hormone? Whenever you,
Maybe we'll not go into the stimulation test.
No,
but
whenever you do the growth
principle
hormone, whenever you think of doing a growth hormone stimulation test or any test for growth hormone, the child, in this case for example, the child should be euthyroid and eucortisol. So it's important to look at the thyroid levels and cortisol levels before you embark on growth hormone stimulation test, because these two hormones hamper or blunt the growth hormone response to your stimulation test. So you need to do the pituitary hormones like the thyroid profile, cortisol, to check that this baby is euthyroid, eucortisol, and then do the growth hormone stimulation test. Once you prove, or if you are going to treat that hypothyroid, hypocortisol, once they are euthyroid, eucortisol, that's when you do the growth hormone stimulation test. And one level of growth hormone should never be done, that everybody knows, right? It is a dynamic hormone. It has thrust and thrust. So you need to do a stimulation test to check what is the level of growth hormone.
So should we stop? Yeah. We'll move on to the next case. Thank you.
The next case is being presented by Dr. Sachin.
Good evening everyone. My patient, 13-month-old male child named Ayan, first by birth order, born of non-consanguineous marriage, Salmani by caste, Muslim by religion, resident of Mankur, heading from UP, brought by and informed by mother with complaint of excessive weight gain since 6 months of age. Child was apparently alright till 6 months of age when mother noticed that child is having excessive gain in weight. It was generalized gain in mass as patient was having proportionate gain in mass in limbs, trunks and face. There is no history of localized swelling of limbs or periorbital swelling. For this complaint, mother has taken 2 consultations, that is at 11 months of age. Weight documented at that time was 17.04 kg, and second at 12 months of age. Weight documented at that time was 17.6 kg. History of there is history of increased frequency of servings in dietary history since last 6 months of age. Initially, child used to take 6 to 7 servings per day, but since last 6 months, child is requiring 10 to 11 servings per day. There is no history of decreased activity, lethargy, constipation. There is no history of any drug intake. No history suggestive of irritability or any obvious visual disturbance. No history of edematous face. There is history that mother is giving history that baby initially baby was having normal size external genitalia, but now she is observing that size of the external genitalia has decreased. In past history, there is history of convulsion at 1.5 months of age. Convulsion was in form of uprolling of eyeball without tonic movement, without frothing from angle of mouth. Convulsion lasting for 5 to 6 minutes and subsiding on its own. There was no postictal drowsiness. There was no history of fever, lethargy, irritability, refusal to feed or excessive cry prior to the episode of convulsion. For the complaint of convulsion, child was shown to private practitioner, was told to be hypocalcemic convulsion and was advised to take syrup calcium. CSF and other blood investigations were not done. No further episode of convulsion. According to mother, child is neurologically normal after the episode of convulsion. Birth history, mother was ANC registered. She had only 2 ANC visits. Weight gain of the mother is not documented during the antenatal period. No history of diabetes mellitus in mother. She has received tetanus and iron folic acid tablets. It was full-term normal vaginal delivery. Child was hospital delivered. Baby cried immediately after birth. Birth weight was 3.3 kg. Was admitted for 1 day for observation and was discharged on day 2 of life with advice of breastfeeding. Child is immunized only once at 9 months of age. Records of immunization and weight at the time of immunization are not available. Dietary history was started on formula feed on day 3 of life in view of inadequate milk output. She was giving formula feed with appropriate dilution. 6 to 8 servings per day she was giving. At 6 months of age, she started giving buffalo's milk to the child. 500 ml of buffalo's milk she was giving. Recommended dietary allowed RDA at 6 months was 869 kilocalorie and intake was 820 kilocalorie with deficit of 49 kilocalorie. At 8 months of age, recommended dietary allowance was there was excess of intake of 116 kilocalorie per day. His frequency of servings increased after 8 months of age. Sir, baby was having 10 to 11 servings per day with excessive dietary intake of 423 kilocalorie per day and excess of protein intake of 25.9 gram per day. In developmental milestone, he achieved head holding at 3 months of age, rollover at 5 to 6 months of age. He is not able to sit with support. He is not able to creep or crawl. Fine motor milestone, reaching out for object, he achieved at 5 months of age. Bidextrous approach at 6 months of age. Unidextrous approach at 8 months of age. Palmar grasp at 10 months of age. He feeds himself with his hands since last 15-20 days. Language milestone, cooing at 3.5 months of age. Babbling at 4-5 months of age. Monosyllabus word at 6 months, bisyllabus at 9 months. Presently is able to speak 2 to 3 meaningful words. Social milestone, social smile at 2 months of age, recognizing mother at 3.5 months of age, stranger anxiety at 8 months of age. He enjoys playing, enjoys clapping, impression of developmental milestone, child is mildly delayed in motor milestone and other milestones are preserved. Family history born of non-consanguineous marriage. Mother is 20 years, illiterate housewife. Father, they are separated, so father. There is no history of obesity in the relatives. She lives in one room with 2 windows and 1 door, pakka house, tap water supply. Kupuswami scale, belong to class 4 socio-economic class.
Yes. Now, what do you all think of this history? What are your first initial thoughts?
Well presented. Yeah.
Come, start saying what you think.
What do you think? Is this baby normal? Do you think based on history, is this baby normal? Some noise must come from this side also, no? Is this baby normal? No. So what are the issues in the history?
Whatever are your thoughts. So again, like we discussed in the first child, onset, progress, duration, and then based on that you will start thinking.
What is the chief symptom he spoke of?
Chief symptom is gain of weight, excessive gain of weight.
Excessive weight gain. Since what age?
Six months of age.
Since 6 months.
When this patient is presented from last 6 months, that gaining weight and suddenly increasing in appetite. So I would like to think first in chromosomal, like Prader-Willi or.
Yeah. So you're talking of, we'll think of etiology later on. Let's
So
just analyze the symptoms.
you are thinking of chromosomal because it started at 6 months? You should have reasons why you are thinking of.
Initially it was normal. Then from last 6 months, initially it has started increasing more food. And because of that gaining weight.
Correct. So what I am saying is that would you think of chromosomal because it started at 6 months, or you have other reasons to think chromosomal?
Developmental delay is also there.
What developmental delay?
Motor delay is there.
So do you have an alternate explanation for that?
Because of obesity.
Because of obesity.
So it is selective, na? If you would expect chromosomal, you would expect a generalized delay. Okay, so he made that point very clearly, that in other spheres it is not affected. Okay, what else are your thoughts? You want to say something?
So he mentioned the genetically also, and it seems that there is some regression in this.
So again, that means when we examine the baby, we'll sort that out probably, but there is a catch there. So it gives you an impression that there may be hypogonadism, but if you have examined obese children, you will realize that what is the problem?
It is embedded in a pad of fat.
So it is buried in the pad of fat, and then you'll have to look for all that on examination. So you cannot really conclude just now. What else?
Actually, gonadal regression does not happen like height. Can anybody lose on height? Cannot. So it may not increase in size in terms of growth, but you cannot. The parents thought was maybe the gonadal size has regressed. That regression does not happen actually. Maybe they are falsely looking at a small looking, or truly looking at a small looking genital, which on examination we will see. And one thing about the chromosomal thing is, if you're saying the child is putting on weight or suddenly becoming hyperphagic by 6 months, it's a bit very early. For a chromosomal causes to have become hyperphagic and obese, that usually happens beyond 2-3 years of life. It happens in the mid-childhood. In the first year, the appetite or the satiety is driven by some other mechanisms as compared to behavior. So the Prader-Willi, for example, like you mentioned, they eat a lot because of a behavioral problem, not because they are truly hyperphagic. Hyperphagia is driven by your satiety center and your mechanisms of energy balance, etc. So if it happens in the first year, They usually poor eaters, they puke a lot, they fail to thrive. They fail to thrive in the first year of life, and then they start putting on weight from second, third year of age.
And any question? Okay. What else? Any other thoughts?
As he is saying that he has increase in appetite, so in terms of endocrinal disorder, to think
I think we are coming back to the same kind of thing. So what is the next question you're supposed to ask in the symptomatology? If a child presents to you with, my child is gaining excess weight, what will be the next question you'll ask to the parent? What will be the next question you'll ask? Yeah, that's correct. What is it? Gaining in height or not? So that's an important question, which would be the most important clue to endocrine versus non-endocrine problems. The second question which you would ask is whether the child is gaining in height. How will this infant's mother be able to tell you if the child is gaining in height? How will you ask?
That the kapade chote.
Yeah, that would be an indirect evidence. Yes, true, because it grows very rapidly. And if you, I don't know, you need to keep changing the size clothes very often, especially in this age group. So if they are outgrowing their clothes sizes, outgrowing in size, then that is an indirect indicator that. So next question would be whether he is growing in height or not. What other questions would you ask?
So how would you know that he is growing in height? Changing clothes could be because of weight.
Outgrowing the size of clothes.
But that is because of weight, no? By and large.
No. It will be shortening of the size of the clothes rather than clothes size. Yes. Even change in, suppose it was a bigger boy child, you would have asked about change in chappal size also. If they are outgrowing their chappal size, are they outgrowing? That is how you ask about poor growth as well as accelerated growth. So if the child is gaining in height, an infant gains too rapidly, so it's not difficult to miss that the child is growing or not growing as compared to.
Do you have that history of
linear growth is there? Growth of, he is gaining in height also.
He's gaining in height. So that makes us think, that narrows us our differentials based on history. So what other things in the history are important to you? So he's gaining in height, he's putting on weight. Which is the other question we would want to know. So when a child is gaining in height and putting on weight, what are the causes? So we'll ask those questions on the history.
It's usually exogenous. The nutritional component is excess of nutrition.
Okay, one is nutritional. Anything else? Drugs, very important. So drugs usually also, if suppose you acutely taken, may not affect height. Chronically injured, which drugs are you thinking of? Steroids. Which steroid will this baby normally get? For what reason he may get a steroid? What reasons are infants commonly or often given? In a chronic intake of steroid, yes, height gets affected.
Height is affected now.
Yeah, in a chronic intake, height gets affected. In acute intermittent, say boluses or whatever, you're hyperphagic and you can put on weight without much effect of the height. So when do you give steroids for short duration of time in this age? So, wheezers. Often they are used maybe very freely. So use of drugs like steroids should be asked first. Anything else? So drugs, nutrition, height, and we said milestones.
Development they already asked. Yeah.
What about drugs like cyproheptadine? What about drug
stimulant?
Yeah, appetite stimulant.
I was wondering that this child seems to have a large appetite. Question is it physiological or it's pathological? I would look at that. For example, hypothalamic syndrome can have a large appetite and obesity. And this child has had some neurological problem earlier, some seizure, etc. So first I would say that because there's so much of increase in calorie and protein, so is it physiological? What does it mean by that? So is it just a habit? Is it just no other kind of a social issues, interaction, so child keeps on eating and therefore the child is gaining weight? And if it is pathological, then what could it be? I imagine a hypothalamic diseases would come with obesity. So we need to look at that. Last thing is that if he is taking so much of more, what is the composition of things? Okay, is he taking too much of fat and carbohydrates and not so much of proteins? Okay, he might go fat. So I would get into details of what he is eating, what's the composition, is it voluntary, is it force-fed, is he happily eating, and if it's pathological. I think that would be, because exogenous at this age, at a little later age it could be a sedentary lifestyle, okay, just not playing, no exercise. But at this age, a normal child is very active. Why is he getting so obese? So he's eating more. We have already said if he's growing well in height, then this is unlikely endocrine. Then this is exogenous. What is exogenous in an infant? I think exogenous in an infant may be even pathological. In an older child, it's certainly environment.
So unlikely endocrine means, like we said, hypothyroid and those, that unlikely. But what about even hyperinsulinism? Would that be a possibility?
Yeah. When so what we are talking of is an infantile obesity. Infantile, like Sir said, that's often pathological rather than just nutrition driven. So looking at the age at onset is very important when you're talking of type of obesity. So infantile onset of obesity are more often related to the constitutional, which means the parents could have been obese and tall as infants, which is called a constitutional overgrowth. Like you have a constitutional delay and short stature, similarly have a constitutional overgrowth. You can have a condition called a postnatal overgrowth, which can again be genetic rather than constitutional, and of course overgrowth syndromes related to anabolic hormones. The anabolic hormones in the body are insulin or growth hormone. You can have an acromegaly growth happening driven or overgrowth syndrome, hypothalamic or overgrowth syndrome due to growth hormone per se, like gigantism, which can happen because of growth hormone or because of insulin. So these would be the hormonal causes of postnatal overgrowth happening in infancy. Besides that, there are other satiety factors or your GI peptides like ghrelin and leptin, which can also drive your appetite and make the baby obese. Those are called paracrine kind of, they are not endocrine kind of hormones, but they are paracrine, which help you recognize the satiety and stop eating. So leptin receptor problems or leptin deficiencies can give you a overgrowth syndrome. So these would be your satiety factors related, hypothalamic injury, growth hormone excess or in hyperinsulinism.
On history, can we rely on that height thing so much, as in what about ectopic tumor which is producing ACTH or something like that?
Okay, so if you're talking of endocrine causes, we are removing hypercortisolism, we are removing hypothyroidism, pseudo-hypoparathyroidism. These are what are the endocrine causes of obesity? Would be hypothyroidism, pseudo-hypoparathyroidism, what did I say, Cushing's, and then conditions like growth hormone excess, and we spoke of.
So that's what I'm saying. Cushing's we are ruling out on history.
Yeah, usually infantile Cushing is a very sick disease. He will not be going on for so long and isolate. That will be more often because of an adrenal tumor, and those children present to you with an abdominal mass and distension, and they hardly live this long with that overgrowth, overweight, whatever. So Cushing's is, they are sick and obese children. Even in older children, Cushing's babies are sick and obese. They are not like playful, active kind of obese children. So Cushing's is out. Hypothyroidism again is out. He's growing quite well. Hypothyroidism out. Pseudo-hypoparathyroidism, again those babies are relatively short, which we will know on our examination assessment. But the fact that he got some seizures in the
1.5 months of age
life,
attributed to hypocalcemia.
Yeah, so that should still be kept in mind, whether it is a hypoparathyroid phenotype causing obesity or related to that calcium disturbance, because pseudo-hypoparathyroidism can present with short stature and obesity. And pseudo-hypoparathyroidism biochemically behaves like hypoparathyroidism. There is a parathyroid hormone resistance. So if there is a parathyroid hormone resistance, you will get hypocalcemia. So that would be the possibility. For syndromic causes, chromosomal problems. So what are the chromosomal or syndromic causes of onset of obesity? One you said was Prader-Willi. Anything else? You know the list, right? Lawrence Moon-Biddle, amongst all these, the overgrowth syndrome, these children are usually normal in stature and obese. If you're talking of a tall stature and obesity, you have a condition called, they're not necessarily obese, they're tall. So is Soto's syndrome. That is not a true hormonal cause. You have a cerebral gigantism secondary to Soto's syndrome. They can manifest at this age with tall stature and little bit of obesity. So, meaning with obesity. So you could have a syndromic cause, you could have a chromosomal issue, or you could have a leptin, ghrelin, those factors of nutritional compounded, and of course amongst the endocrine it would be pseudohypoparathyroidism as the cause.
Should we move on to examination?
Yeah. Now, one thing in your history, besides, though this is a tiny baby, small baby, in your history, besides looking at whether the child is putting on weight and height, you should also ask for mental subnormality, which you did ask. Should also ask for vision issues, like nighttime vision problems you get in retinitis pigmentosa as part of your syndrome, night vision issues. Any ophthalmic issues you should ask. And the weight-related secondary comorbidities of this age, it's a bit early to expect, but snoring, nighttime wakefulness, so those things you should. Stress incontinence, so bedwetting secondary, not in this age group, secondary bedwetting, walking your limbs, etc. should be asked for in the history.
What has parathyroid got to do with obesity?
In pseudohypoparathyroidism, it's a gene defect, PHP type 1, which is also known as Albright's hereditary osteodystrophy. They have the phenotypic features of something like a skeletal dysplasia. They have short trunk, they have short fourth metatarsus, big head, and they have obesity as associated feature. Maybe it's a relative obesity which you see in relation to the stature and the weight, but they are obese and short, or not, obese and short, so that comes as the endocrine cause of obesity. Yeah.
Shall we examine the baby? Tell us, start with your findings.
Baby is apparently obese, euthermic activity is good, heart rate is 110 per minute, respiratory rate 28 per minute, regular abdominothoracic, peripheral pulses well felt, normorhythmic, no radiofemoral delay, blood pressure 92/56 in right upper arm in supine position, which is near 50th percentile. Anthropometry wise, weight is 19.4 kg, which is more than +3 standard deviation. Length is 83.2 cm, which is between +2 to +3 standard deviation. Head circumference is 43 cm, which is between -3 to -2 standard deviation. Mid-arm circumference is 22 cm, which is more than +3 standard deviation. Weight for height is more than +3 standard deviation. Waist circumference is 64 cm, hip circumference is 70 cm. Waist hip ratio is 0.91. Upper segment lower segment ratio is 1.51.
Waist one is, I'll read out what is not required. So waist hip ratio 1, we don't have the normal ratios for children. 1. 2, it is waist hip circumference, which correlates with your visceral obesity, which correlates with your metabolic syndrome and further problems. So in babies, especially this infant, waist hip ratio may not have any implication in terms of assessment for comorbidities. Okay, so what you're essentially going to talk of is the BMI. So what is your BMI?
BMI is 28.16 kilogram per meter square, which is more than, there are no standard chart for 13 months, so for 2 year, more than 95th percentile is 19.4.
Yeah, so any child who is having more than 23 absolute number is obese, and who is having more than 27 is overweight, and more than 27 is supposed to be obese. So this child is 28. 28. So he is obese. So from your BMI you're telling you this is obese. Okay. And the height here is how much?
83.
Length is 83.2 centimeters.
That's what centile. Height age is what?
Height age is.
So you talk in terms of height age, weight age.
2 years. 2 years.
And weight age? What is the weight of the child?
19.4 kg.
So weightage is?
5 years.
Yeah, rough by your mnemonic it comes something like 5 years. So weightage is 5 years and height age is about 2 years. And BMI is way above the 97th centile. So how do you interpret this as?
Obese child with linear weight growth, but weight more affected than height.
Yeah, so this is like a height not affected. Height is well above the 50th centile. So this is exogenous, though we call it exogenous. Exogenous does not necessarily mean it is physiological. So though we say exogenous need not be physiological. Which essentially means it's the environmental factor which is contributing to the weight of the child rather than an endogenous factor which is contributing to the weight of the child. Okay. You mentioned the head circumference was 43.
Yes, ma'am.
So is that alright for this child? What
is,
age is he?
He is 13 months old. It is between -2 to -3 standard deviation.
So what do you interpret that as? What do you interpret that as? It's less than it is less than 2 standard deviations. So meaning it is small, right? Head circumference for this child, despite being okay in terms of weight and height, his head circumference is small.
But we must also remember that his development is normal.
Yes.
And except for gross motor, his development is
And
normal.
some seizures, some such CNS issues in between. But we'll keep that in mind. His head circumference in relation to his length also is small. In relation to his age, of course, is small. It's also small in relation to his length. We'll keep that in mind and see what that means. What else do you have in your examination findings? What else is important to assess in an infantile obesity besides the anthropometric?
Skin fold thickness.
Yeah, that's very difficult. How do you assess skin fold thickness? Have you seen one? There is a mumbling, but what did that mean? Harpendine's caliper. Have you seen it? Have you seen it? No. So it is
Will
not.
you please repeat what you said? We couldn't hear anything. What did he say?
Harpendine's caliper, he said. Harpendine's caliper. It is given in textbooks, pictures. It's also used in community surveys.
Is it available in the market here?
It is not available to be bought like that. Maybe from your instrumental or the surgical instrument market you can get it. It is like any caliper you use in maths compass box, but it is a bigger kind of a caliper. People use fundal height with that caliper in pregnancy and all. So Harpendine's caliper is to measure the skin fold thickness. If you are saying that, you should know, I guess, everything about that Harpendine's caliper. Where do you measure for skin fold thickness? Do you know? Triceps. Triceps means it's the
anywhere, but triceps or even in the abdomen it can be measured.
No, so it is usually measured in the triceps or in the intrascapular region. So your adiposity is measured, or you have reference numbers for intrascapular region or in the triceps. Is there a benefit of using a caliper to measure as compared to, say, just take the BMI as your measure of obesity? So what are the caveats of using BMI as a indicator of obesity? When will a BMI not be...
Thickness will be able to differentiate between visceral and subacute?
No, fat is everywhere, visceral, subacute. How can you check visceral fat with a caliper? You need to do an MRI. You need to do some kind of imaging to see the subcutaneous fat. So what is the caveat of using a BMI? Do we need him?
अब 2 मिनट बाहर लेके
What is the caveat of using a BMI? When can BMI wrongly be high and the child or person may not be obese? So BMI is an equation is equal to, what is BMI calculated as? Weight upon height and weight. So weight, when you say, especially when you have, say, an athletic body, or you have a bodybuilder, you have more of protein and mass, your BMI can still be high. Okay, so that is not true obesity. So the only caveat of using BMI as a surrogate marker of obesity is only when the muscle mass is more as compared to the fat mass, and you're erroneously putting that person as an obese person. And then there are various methods of assessing obesity. One is your skin fold thickness. You can do the MRI also to look at fat, but those are in a community setting. BMI has a good correlation with diagnosis and assessing comorbidity. So we still use BMI as a marker of assessment of degree of severity of obesity. And the cutoffs we must know, 23 and 27, an absolute number, but you use your centile lines to define your obesity.
So now that you have examined, how would you give your diagnosis as?
Sir, 13-month-old child presenting with complaint of excessive gain in weight since 6 months of age with hyperphagia with mildly delayed gross motor milestone with no significant family history with past history of convulsion attributed to query hypocalcemia, most likely exogenous obesity, to rule out other causes of endogenous obesity like Prader-Willi and Sotos syndrome.
So should we examine the genitals or what should we do? So what did you see for systemic examination in a child with obesity besides? So in general examination you look for blood pressure and you look for striae like you mentioned. What else you see for a general
micropenis?
Then genitals you observe for any presence of micropenis, descended hypogenitalism, hypogenitalism.
Ocular and ear examination.
Eyes examination for?
Retinitis pigmentosa
or
any visual field defects.
Field defects, okay. What else would you see for a general examination?
Ear examination as nerve deafness is present in some syndrome like Alstrom syndrome.
Yeah, so that would be an auditory examination rather than your ear exam. Okay, what else would you see for? In musculoskeletal anything you would see
mid-facial
so you see
structural anomalies.
Mid-facial
for syndromic features.
Okay, so in syndromes essentially eyes like you said, and you look for features of skeletal affection. For example, Blount's disease is something which is very common in this age group. They have a lateral curving of the tibial bone, so they walk with some amount of curvature of the tibial bone because of the medial malleolus being prominent. That's a normal kind of an affection which improves over a period of time. Blount's disease meaning curvature, tibial lateral curvature of the tibia. Also look for limbs and pain, how the gait is in terms of slip capital femoral exercises is present. Also look for features of striae which we mentioned. In systemic examination, see obviously for a liver. You should look up for a liver, for fatty liver which is present sometimes in some of these children, and organomegaly and so on and so forth. So this baby has hypogenitalism. Did you measure the stretch penile length?
2.3 centimeter it is. Okay. Micropenis.
Okay, so 2.3 centimeter is micropenis, and gonads are descended?
Yes, ma'am. Descended bilateral calculation.
Fine. And what is the feel? So descended volume, feel, all that you should mention, because just micropenis with good scrotal development is different as compared to poor scrotal development, poor descended gonad, poor feel of gonad. So that also you should complete in your genital examination. So there is a micropenis, there is normal blood pressure, no liver palpable and high BMI. That's only about a small head circumference. So what does that bring to your mind as, what will you now do with winning? What further workup or evaluation you would want to do?
I'd like to rule out endocrine causes of obesity as he's most likely endogenous obesity because he's not having any dysmorphic features. There is history of hyperphagia. Then generalized fat distribution is there. Developmentally he is normal, ma'am. Blood pressure is normal. But
so what endocrine problems you would want to evaluate for?
Cushing syndrome. Then hypothyroidism, hypopituitarism.
We discussed that on history. Madam said that hypothyroid is unlikely because the height is good, length is good. Cushing, she said, is a sick baby. So Cushing's is ruled out. So we discussed all that. Your blood pressure is normal, there's no other finding, no striae, all that. Okay?
This on examination and history you're getting the complex of features of being obese. Mental subnormality, you're talking about more motor as compared to other fields of assessment.
Would you not give him benefit of doubt for his weight?
But even sitting, he said, was around 9 months, 10 months of age.
So you should give him concession for that. Huh?
Okay, we should give him. Okay, if you put in the perspective the seizures and the some CNS issues which he's had and the small head growth which he's having, you put a CNS problem along with that kind of obesity. If you look at CNS with obesity, because microcephaly in a somatically driven growth, your height, head growth, everything should be appropriate for the child's age. You cannot have it.
He had only one seizure and then he started becoming obese.
Yes.
And he didn't have any CNS symptoms after that. I mean, is it common that way to have only obesity as a presentation after CNS?
No, you picked that up as hypocalcemic seizure at that point of time, but there was a sequential or what you would say simultaneous corollary given by the parents saying that post seizure this child developed increased appetite and then developed obesity, etc., and then some mild developmental delay. And if we put that micropenis and hypogonadism together, if you put that micropenis 2.5 centimeter if it is there with obesity,
2.5 is
2.5 newborn.
You are the endocrinologist.
No,
I cannot tell. I
no,
cannot
3.5 plus. If you go exactly by numbers, 3.5 plus minus 0.7 is in the newborn. Now this baby is 3.5 plus minus 7 in a full term baby is normal penile length. So what is this baby's age here right now? 13 months. So you are expected to be at least, you are supposed to see the FDs and all, but even at least newborn measurement should be there at 13 months of age.
Less than 1.9 centimeter. I'm sorry.
That's micropenis.
Yeah.
What is normal is what we are saying. Micropenis 1.9, you can't talk of 1.9 centimeter at 4 years.
You said micropenis for this patient, this child.
Hypogenitalism. Because
Hypogenitalism,
penile length
micropenis and
penile length is less than normal, 3.5 plus minus 0.7 if you take the cutoff. And it has to be something like 2.7, 2.8.
yeah.
So that would be the kind of lower SD for the penile length here. If we assume that his measurement is correct, then 2.5 has to be on the less than the
Would you not
SD.
think that it's a buried penis?
Assuming the measurement is correct. Of
So
course,
you
buried
look
penis.
for buried or
I look for buried penis.
If your measurement is correct, then if you not like properly stretched and taken, then of course we can debate on that whether it is normal or.
You give us both scenarios. Mentally normal without micropenis and obesity.
Okay, I thought that was simpler from a postgraduate's point of view to look at mentally subnormal hypogonadism and obesity coming up. Need not necessarily be Prader-Willi. If you're getting all the three complexes together in any obese child, we are talking of syndromic causes of obesity. If you're saying this mental subnormality is not there, and if you're saying there is no hypogenitalism, in a child who is appropriate in terms of height as well as weight, you're, like Sir said, you're talking of nutritionally driven causes of obesity, hypothalamic causes of obesity, leptin-related obesity, or overgrowth syndromes, constitutional overgrowth. In terms of constitutional overgrowth, it is important to figure out whether the parents are also obese as children. Then that puts it simpler. So this child would also say outgrow the kind of obesity which is present now. Unfortunately, infantile obesity does not track as adult obesity as compared to childhood obesity. For example, if the age at adiposity rebound happens by about 3 years or 4 years of age. The child is obese in the first 5, meaning by 5th year and beyond. That tracks as obesity subsequently into adolescence and adulthood and has an implication in terms of comorbidities later on like metabolic syndrome, etc. So, and non-endocrine problems like what is that? Pancreatitis, cholecystitis. All non-endocrine problems can also be there in a person, in a child who is tracking on to adult obesity. So childhood obesity tracks as adult obesity. Infantile obesity does not necessarily track as adult obesity.
One more question. For this penile length, I mean this child is 13 months. Do we have a figure which says below this it's abnormal?
Yeah,
So that
absolute.
is at birth, no? You said.
No, -2 standard deviation. If you go by numbers, you need to look
No,
at
in the exam
-2.
they won't get a chart, no? So they have to decide on numbers. Give us
If
a
you
rule of
say
thumb.
in the newborn period your diagnosis is say 1.9, it can't be less than 1.9 at any age.
Correct.
It has to grow more than 1.9 if the growth is say normal. So absolute number can be taken as 1.9 and less as micropenis. But ideal answer would be less than 2 standard deviation, and there are centile charts available in standard textbooks of penile length, which is available.
So what you do in the exam is give the length and say you want the charts.
Or if
Play
it is
safe.
less than 1.9, say it is micropenis. That would be safer to say that. Yeah.
Which hypothalamic disease will cause obesity like this with only obesity presentation?
No, I would put that hyperactivity, mental I would personally feel that this baby is not mentally normal and have some kind of hyperactivity and hyperphagia, which is of a sudden onset. And it was apparent, like history says, he was okay for about some time, and then sudden onset, increased appetite, not driven by overfeeding or something. And also
Selectively affecting the feeding center.
yeah, satiety center. Other features would also be there if you look for example, hypothalamic syndromes can have behavioral abnormality. They could be temperature instability, autonomic disturbances present along with that. So if those are evident or those are looked for, you would further make a strong case of hypothalamic cause. You would more strongly think in terms of disturbances in energy balance in this age group, leptin, ghrelin, hypothalamic driven factors as cause of infantile obesity. If you are looking for a pathology, if you are looking at a normal thing, it could be, like I said, constitutional postnatal overgrowth, which could be there even till 3 years of age. After that, they settle down. That would be.
Rajesh, you want to comment on this mental subnormality? We don't want them to go with confusion. Just give us that way of knowing whether it's only motor, differential and all that. Just tell us.
Yeah, no, here, if his history is correct, then he did tell us clearly that all the other 3 domains were normal and it was only gross motor delay. So then we wouldn't really call it mental subnormality. Of course, we'll have to confirm that the history is correct. So, sir, any comments on?
Comment on management. Okay, because or would we tell the parents no, nothing can be done?
That is a very difficult question as to management. Obesity is not a medical disease that you give a medicine and then you take care of it. There's a lot of talking, lot of reinforcement which needs to be done. Looking at the diet pattern, activity, and if you're looking in this child specifically, I would want to work up to see if there is any CNS cause here.
Have you done any tests on this? What is?
If you're seeing.
Sudha, 1 minute, we can just.
Sir,
quickly tell us.
Serum cortisol level is done morning 8 a.m. It is 6.3. Then thyroid stimulating hormone 1.27. Free T4 is 0.99. MRI brain is also done. Suggestive of pituitary gland measures 2.6 into 5.1.
was done.
Pituitary sections were done for pituitary size study. Other study is normal. 2.6 into 5.1 mm. Pituitary height is less than mean height for this age group. Little pituitary study was indicated, advised.
But if indeed you are coming with this report, some child or your presentation in the exam is with the reports available to you of a small looking pituitary gland in an otherwise well grown kind of a child, you would want to look at what is happening to the hypothalamus. An evidence to look at hypothalamus, say I'm from a hormone, so I would talk in terms of doing a prolactin, which will tell me whether the hypothalamus is affected or not. Of course, neurologically on MRI, you would want to also see whether hypothalamus, any issues are there in the hypothalamus. Structurally, they could still be normal, but functionally, if you look at, say, prolactin, which is the hormone getting released from the pituitary, but has a negative inhibition by the hypothalamus. If that hypothalamic inhibition is released, you get a high prolactin. If we have a high prolactin, it could be two things. Either there is a prolactin secreting problem from the pituitary, or the hypothalamic suppression of the prolactin secretion is removed. So high prolactin could be a primary pituitary prolactin secreting problem, or it could be a hypothalamic injury. So that would be the further need there. But I think I won't go into that aspect of the further testing. In terms of investigations per se, a child of this kind of a background would warrant an investigation, maybe not to such a great extent, maybe to look at what is happening in terms of calcium levels since he through hypocalcemic seizures, look at what is happening to his vitamin D levels because he's grown too rapidly. In terms of nutritional issues, you would want to see. You would also want to look at the fundus to see whether there are any fundic changes, retinal changes. You may do a bone age, which would help you to correlate with his height, age and maturation, whether it is advanced or appropriate for the child's chronological age. And then I would stop in terms of investigations. And we would look at nutrition and nutritional management, which is easier said than done. Children this age do not really follow, any age for that matter, do not really follow timetable provided to them. So though you have low protein diet, high carb diet, this diet, that diet, the essential thing is let the baby eat a balanced meal, and what he should not be fed on would be told to the parents. For example, some of them give chocolates morning, evening, night just because the baby takes only chocolates. He doesn't like anything else, or chips or wafers. So high carb, high calorie kind of a diet should be avoided. That could be a guideline rather than giving a prescription of a diet. If you give a diet chart, everybody will take it home and they'll just sit on that diet chart and not follow it. So it is better to tell them what should be avoided and what should be provided in. So kind of dietary guide rather than a diet chart which can be provided. There is no medical treatment, there is no medicine like I mentioned, and children this age are usually very active. There is no need to put in a kind of activity regime, half an hour running or 1 hour running. All those things need not be emphasized upon as an advice. Keeping the child active and not trying to take the baby on the vehicle or cart. As much as physical activities the baby can do should be advised. So that would be the essential advice. Drugs don't come in picture in a chromosomal, in a syndromic cause of obesity. If it was a leptin deficiency, which you could further work up, if it's a gene defect like MC4R, meaning there are various genes which cause, you could give leptin as a treatment to bring down the weight. That's not available easily here, though we can measure the leptin levels. We don't get leptin as a therapy here. So there is a leptin deficiency, you could treat the child with leptin. There is a chromosomal defect, you are left with nothing but counseling them accordingly. If this child was a bit older, say 4 or 5 years old, you would look for comorbidities like insulin resistance, dyslipidemia, hypertension, etc. If these comorbidities are present, then you treat according to the morbidity which is present.
Yeah, I think we'll conclude the session now. Dr. Sudharao, thank you so much. You were really excellent and we learned so much. The next broadcast will be from Chennai on the 7th of October, 2:30 p.m. onwards, and Dr. Bala from Kachi Kamakoti Child's Trust Hospital will be managing that. See you there.
You have a hypothalamic